Welcome to NINR and NINH. I'll be maybe the first to say that publicly. We're really glad that you are here. I'm just mostly going to go over some of the logistics for the day, but before we do, as you know, for the last almost 9 months or so, we've had the pleasure of having Dr. Kathy Anderson serve as the acting director of our Division of Extramural Science Programs. And Kathy recently started a new position, a new permanent position at the National Eye Institute. So we're very fortunate for and grateful to Kathy for the time that she spent at NINR and wish her all the best in her new position. But we are also really fortunate to have Dr. Kay Wonke, who is now serving in this acting position since actually late July. So Dr. Wonke is on loan to us on detail from the NIH Office of Disease Prevention, where she serves as the Deputy Director for the Tobacco Regulatory Science Program. And her PhD is in clinical psychology and further trained in epidemiology, including genetic epidemiology. So welcome, Kay, into your new role, new acting role at NINR, although I know you've already been here for about a month and a half, so you're starting hopefully to get into the swing of things. So just a few words about today's council. I will give a sort of brief update on a sort of retrospective look at some of the activities that have been occurring since last May when we met. And then we will hear, which is probably the thing that we're all most excited about, but we'll hear from Shannon and get and some insight from her into what her thoughts are for the Institute and the future direction and vision that she has for it. And then after we hear from Shannon, we'll get an update from our CSR colleague, Dr. Delia. I'm so sorry, Delia. I know I'm going to botch this. Olafokunbi. Sam, who will tell us a little bit about some important study section changes relevant to NINR, and it will be followed by, obviously some discussion amongst council members for any questions and comments that people have. And then finally, we'll provide an update on NINR's Training Pathways Working Group of our council, and that will be led by Dr. Jessica Gill. And this is an effort being co-chaired by her and Dr. Shirley Moore. And she'll just give us an overview of the steps and the process thus far, some of the themes that are starting to emerge, and a timeline for where they think the recommendations will be ready to present to you all. And then with that, let me jump into some of the actual sort of more nitty-gritty logistics for the day. So as I think you could tell, this is a virtual only meeting that is being broadcast live and will be archived via video cast. This is a one-day meeting only with open session from 11:30 a.m. to 1:30 p.m. We'll have a short break for half an hour, and then we'll begin closed session at 2 o'clock. And a separate meeting invite was sent out to council members and all applicable staff with the login instructions for the closed session. So just one other thing I would point out is just because these are virtual meetings, it's always helpful to be able to see all of your faces. So if you're willing, I encourage you to turn on your video so that we can see you. And then in terms of absences, I think the only one actually is a last minute absence from Dr. Moore. And so now I'll turn it over to Kay to go over our council procedures and related matters.
Thank you, Dr. Schwetz. And I want to extend a thanks to our previous executive secretary, Dr. Kathleen Anderson, for her guidance and support as she passed me the baton. And I want to thank the NINR staff who extended me a warm welcome and a lot of assistance as I've been transitioning into this position. I also want to echo Dr. Schwetz's comments and welcome Dr. Shannon Zank, and I want to convey the collective enthusiasm and support from the entire Institute for your leadership. And I also want to welcome and thank the council members. We appreciate the contributions you make in lending your expertise to advise NINR. And I want to welcome and thank the entire NINR investigator community. I look forward to meeting and working with you and learning more about the research that you do. So as we continue, I'd like to ask those on the call to just to remember to mute yourself if you're not speaking to eliminate the background noise. So as Dr. Schwetz said, the meeting is being broadcast live on NIH Videocast website, and so it's archived for playback. And I want to remind you that as special government employees, council members may not engage in any lobbying activities while receiving pay from the federal government. Further information regarding conflict of interest and confidentiality requirements are posted in the electronic council book, so please review if you haven't already. I'll be giving more specific instructions about conflict of interest and confidentiality at the beginning of the closed session later this afternoon. Now I'd like to have a consideration of the minutes from the previous council meeting. Minutes of the meeting from May were made available to you in the electronic council book for your review. May I have a motion to approve the May meeting minutes?
This is Kai Moore. I move to approve the minutes.
Thank you. And do I have a second?
Second, Nana Benagalo Montano.
Thank you. And the motion to approve the meeting minutes carries. Please note that the date for future council meetings are listed in the open session materials in the electronic council book. So please review those and let me know if you have any known conflicts with those dates. Our next meeting is scheduled for January 25th of 2021. Now I'll turn the meeting back over to Tara.
Great, thank you. Okay, let me share my screen and my slides, and hopefully I do this appropriately. I think as much as we've done it over the last 6 months now, it would be a breeze, but let me go ahead into okay. So I hope that you can just see my slides and not the notes.
Comment.
I'm sorry, what?
You can see your comment.
We can see your notes.
Oh, okay. So I just switched it to make it so that you could. Okay, let's see. How about that?
That's great.
Okay. All right. Well, it defaulted to the right setting and I tried to correct it. See, I should always trust the technology, I suppose. Okay. All right. Well, thank you. And as I said, this will be a bit more of a kind of retrospective look at the last 3 months since we've last met. And then we'll get into what I'm calling the more prospective look at what the future will hold for NINR that Shannon will offer. And we'll sort of have a passing of the baton, if you will, as well. So, you know, I'll just again echo my good mornings to all of you. As again, we're really pleased that everyone, both you know, on the council and others in the community, are able to join the video cast. So as I indicated, we're really excited to have with us Dr. Shannon Zink, who is now the new NINR director as of yesterday. So, you know, we're just throwing her in deep, you know, so that she starts in her second day. She's already helping to lead council. So we welcome her here and really look forward to seeing what she has planned for the Institute and her carrying out her vision for the future. So Shannon is joined by several other new NIH Institute directors. You may have seen the announcements, but 4 others have been selected. And actually one has started, and that's Rick Wojciech, who is the director of the National Institute of Environmental Health Sciences. He was previously the deputy director of the Institute. We also have Dr. Michael Chang, who is going to be heading up the National Eye Institute, and he's coming to us from Oregon Health and Sciences University. And then Dr. Lindsay Criswell, will be the new director of the National Institute of Arthritis and Musculoskeletal and Skin Diseases, or NIAMS. And she is coming to us from UCSF. And then last but definitely not least, Dr. Rena D'Souza has been named as the director of the National Institute of Dental and Craniofacial Research, or NIDCR. And she's coming to us from the University of Utah. So Shannon has a nice cohort that she gets to come on and to NIH with, and look forward to working with these folks in the future. So I think this is obviously something that's still on people's mind, and that's the coronavirus. You know, and I encourage everyone to continue to check out the resources that are available, both on the NIH, CDC, and others, including the grants.nih.gov link, which provides a lot of very updated information on the impact on grant applications. So we also put out an NIH-wide strategic plan for COVID-19 research, which I hope you all have seen. And it just outlines a really high-level framework for accelerating therapeutics, vaccines, and diagnostics across all of NIH. And it has sort of 5 major themes to increase our foundational knowledge of coronavirus and of SARS-CoV-2 and the COVID-19 disease, to speed up testing through one of our initiatives, which I think I mentioned previously in May, which is RADx, which is a large initiative aimed at really advancing diagnostics and the implementation of those diagnostics. And then supporting public-private partnerships through efforts like ACTIVE, the accelerating coronavirus therapeutic interventions and vaccines. And then the Operation Warp Speed, which is a trans-governmental effort that NIH is involved in. And then there are, obviously to study preventive treatment and behavioral and community prevention practices and ensure that those who need it most are able to access the different diagnostics, treatments, and therapeutics. So to highlight a few of those, the accelerating, let's see if I botched the name, accelerating COVID-19 therapeutic interventions and vaccines, our ACTIVE initiative, which is, again, this is a public-private partnership that has a whole host of companies that are involved with this. And just on this slide here, and I'm not going to go into a tremendous amount of detail, but there have been several studies that have been launched as a result of ACTIVE. So technically there are 4 master protocols for ACTIVE, and they're focused on a couple different areas. ACTIVE 1 is focused on immunomodulators. ACTIVE 2 and 3 are looking at monoclonal antibodies alone or in combination with other therapies, and they're either inpatient or outpatient. And then ACTIVE 4, which was actually just launched last week, is looking at antithrombotics. So a lot of stuff going on in this space, and hopefully we'll continue to see good results coming out of all of these studies. In addition to that, there's obviously a lot of work around prevention and vaccines. So the one that maybe is out most in front is the Moderna trial, which began its phase 3 trial back in late July, and is aiming to enroll 30,000 adults, I think, by the end of the month. So we'll obviously continue to wait and see the results of that trial, as well as many of the others, including the AstraZeneca trial, which actually was in the news a bit over the last week or so. But I also want to point out the COVID-19 Prevention Network, or CoVPN, as we call it. And this network is a way for participants to sign up to participate in a variety of different trials and is really aiming to enroll a lot of people, and was actually stitched together by merging 4 of our existing NIAID funded clinical trial networks. So it's definitely worth checking out. As I mentioned previously, RADx is our big diagnostic effort, and there are multiple components of RADx. I won't go into tremendous detail here because I think we've already talked about them last month, but just to note a few points that the ones that NINR has been involved with really in a meaningful way is RADx UP on underserved populations, which is a $500 million effort to support a series of interlinked community engagement projects, community engaged research projects, I should say, that are really focused on implementing strategies to enable and enhance testing, and not just testing, but sort of accessibility to testing, the uptake of that testing within a series of vulnerable and underserved populations. Again, trying to target those populations that need the testing the most and that are hardest hit by this virus and disease. The other effort that NINR has been involved with is the RAD effort, which is this $200 million effort that's trying to develop novel approaches novel non-traditional approaches, I should say, to testing. So, things like identifying biomarkers that are predictive of disease onset or severity, things around wastewater testing, looking at aptamers and how they can be utilized. And so a variety of different approaches, and many of these things are just starting to get kicked off. So I think stay tuned for a lot of activity over the next several months. Now, we also wanted to highlight and sort of one kind of concise slide, the different efforts that NINR has been involved with around COVID. As I mentioned, RADx UP and RADx RAD. We've also provided some preliminary review of applications for some of the technologies around in the RADx tech space. We've also signed on to several funding opportunity announcements, including ones focused on the social, behavioral, and economic challenges around COVID. And I encourage you all to go to the website, check those out, both on our NINR website, as well as they can be found on the grants.gov site. And then, of course, ACTIVE, our palliative care research cooperative, has been added to the trial sites for potential involvement in future ACTIVE trials. So taking a sort of step away from COVID for a moment, which seems we very rarely get to do these days, but I think that this is an important thing to highlight and something that is very much on the minds of the leadership, both at NIH and at NINR, and that is talking about structural racism and the diversity of our both our staff at NINR within the Institute and the workforce that we support in the extramural community. And of course, as we're going to hear about later today, the Pathways Working Group is obviously thinking a lot about training, and they've been charged with making recommendations on improving diversity as well. And we're reviewing our ESI programs and evaluating our technical assistance and post-review decision-making to also ensure equitability and inclusivity. Internally within NINR, we've established a committee we call CHANGE, and that stands for ceasing harassment and nurturing a good environment or change. And this is really trying to reinforce a culture free of discrimination and harassment across NINR. And then across the agency, there's a longstanding commitment to improving the workforce diversity and supporting research to eliminate health disparities. And so there's an effort ongoing to really, a renewed effort to really think through these different aspects, and facets, and to try to have, to take a different approach on how we have been tackling this. And so I think there'll be a lot more to come in this space in the future. Okay, the status of, now shifting gears just completely, but the status of the FY21 appropriations. Basically, we don't have FY21 appropriations bill just yet. I'm not sure how imminent something is, but I think we're all preparing here for a continuing resolution. And so what that means is that just keeps us at basically the level we were at in the previous year, which for us would be FY20, and would put us at around $170 million a year. So stay tuned, and we're all waiting with a bated breath to see how this all plays out, and how, given that it's an election year, I think the likelihood that we'll get a CR is pretty high. But for how long we have that CR, whether we end up getting a full appropriations bill or not, I guess is yet to be determined. Okay, and on to some more distinctly NINR focused news. It's been quite a busy time at NINR since May, and I just want to provide you with some updates on NINR staff and activities. Other than obviously a big one with Shannon, which I mentioned previously. We are also going to be welcoming later this month a new NINR acting deputy director. So I'm pleased to announce that Dr. Susan Old is joining NINR as our acting deputy director at the end of the month. And she is currently the deputy director of the Division of Extramural Activities at the National Institute of Allergy and Infectious Diseases, or NIAID. And she's had quite an impressive tenure at NIH over the last several years, and has worked at a variety of different institutes in a variety of different settings. She has such an impressive CV, and so we're really excited to be able to welcome Susan to help Shannon in the leadership of the Institute. Additionally, as I announced previously, we've welcomed Dr. Kay Wonke to serve as the acting director of our Division of Extramural Science Programs. We also, through a little arm twisting, convinced Dr. Martha Matoka to serve as our acting deputy director of our Division of Extramural Science Programs as well. So we're grateful to Martha for her willingness to serve in this capacity, in addition to being the chief of one of the branches within the division. And then finally, as you know, Dr. Terry Armstrong had been serving as our acting scientific director, and she obviously was on detail to NINR from NCI, and her detail ended, and Dr. Jessica Gill has graciously agreed to return to her previous role as the acting scientific director. And so really thankful to her for her willingness to be flexible and to step in and help where needed. It's been really a great help and benefit to me as I had been serving in this acting leadership role. I also just want to mention that we have an announcement out sort of on the street, as we say, where we're seeking a permanent director for our Division of Extramural Science Programs. So the link to the website is here. I encourage everyone to check out the vacancy announcement. Applications are being accepted through October 23rd. So we're hoping to identify a really strong candidate to lead our extramural division. Additionally, I want to acknowledge one of our intramural researchers, Dr. Polly Joseph, for being selected as one of the American Academy of Nursing's 2020 class of fellows. And so obviously this is a big honor for Polly, who has been serving as a tenure track investigator and our chief of the sensory science and metabolism unit within our intramural program. And so we really congratulate her for this great honor. And then just some other sort of maybe fun news to share. NINR was featured on several podcasts. Dr. Jessica Gill and Dr. Kimbra Kinney of the Uniformed Services University of the Health Sciences discussed their research on neurofilament light chain as a biomarker following traumatic brain injury in a segment of the American Academy of Neurology's latest podcast. And then I had a really fun and interesting chat with Dr. Lisa Kennedy Sheldon with the Oncology Nursing Society to discuss just a lot of variety of different issues that were ongoing at the time at NINR, and in particular responding to COVID-19. So those were, I think those are really, really nice ways to celebrate the variety of different things that NINR is doing, and encourage you to check out both of those podcasts. Additionally, back in July, the NIH Office of Intramural Training and Education held a panel on careers in nursing research that over 200 people watched live. And I'm sure that number has ticked up since it's been posted, but they're including people from 3 countries outside the US. So this was very well attended, and it allowed the attendees to hear about the many career opportunities open to nurses with PhDs, and it featured speakers that you can see here, our very own doctors Patty Brennan, Leo Saligan, and Polly Joseph. Again, another fun thing that I encourage you all to check out if you have a spare moment. Oops, double click that. Then some recent NINR virtual events, of course virtual because we're all still teleworking, but NINR hosted the workshop on genomic response to the social environment, implications for health outcomes back in June. And this very transdisciplinary event helped to address the relationship among genomics, epigenomics, gene expression, microbiome, et cetera, and the social environmental factors, and then health outcomes across a variety of different populations, conditions, and the lifespan. And we also were able to celebrate in a different way our 2020 Summer Genetics Institute. So the Institute itself was canceled, but we were able to host a 20th anniversary symposium to mark this milestone anniversary. And the symposium was viewed live by over 1,000 people. And so we're really fortunate to be able to have that broad reach that we had this year. But of course, look forward to being able to do this in person next year. And it honestly has made us rethink our approach to this, and maybe, especially given the attendance, how we could incorporate more video cast into what we're planning for the next time around. And then, I'll just also note that we kicked off the SGI with a special speaker. So NIH Director, Dr. Francis Collins, gave a nice introduction and welcome to the symposium, and obviously talked a lot about the launch of this program and his longstanding support of it. Additionally, we had the boot camp, which was also held virtually for the first time in August, and also had 3,000 live views. So again, silver lining to all of the changes in our work that we're doing as a result of COVID has been this increased, I think, interest and attention that many of our efforts have been given. And this year's boot camp explored the impact that artificial intelligence has in the evolving healthcare environment and the overall efforts to improve the quality of care for patients and families. So again, you can continue to watch these on the internet and check out either the NIH website or the Videocast website. Both have the information for these. And finally, some upcoming virtual events that we want to bring to your attention. We have a workshop that we're hosting on innovative models of care for reducing inequities in maternal health that we're co-hosting with the Office of Research on Women's Health and the National Institute on Child Health and Human Development. So encourage you all to participate in that. Additionally, there's a Symptom Science Advances in Oncology Nursing virtual event. I know it seems like a far ways off, but it will be here, I'm sure, before we know it, in February of 2021, actually. I know that says 2020, it's 2021. And this will be presented by NINR, the National Cancer Institute, and the Oncology Nursing Society, and really highlight science advances in oncology nursing, and hopefully provide an opportunity for virtual networking and research mentorship for the next generation of nurse scientists. Additionally, I want to just highlight that we've started the process for developing the next strategic plan, and it's going to be released in the latter half of 2021. And we've assembled really an amazing working group under the auspices of this advisory council to assist us as we begin thinking about the plan. And it's being co-chaired by Dr. Yvette Conley, who has graciously agreed to do this along with our NINR's own Dr. John Grayson. And so we really look forward to getting feedback and recommendations from this group, and to begin to think about ways to encourage broader feedback opportunities from the general public and the broader external community. So stay tuned. I look forward to seeing how this evolves, and this plan will be published sometime in 2021. And just briefly, just to talk about a few pieces of science here, I wanted to highlight two really exciting NINR research highlights. So in the area of robotics and wearable devices, NINR supported researchers have developed what seems like a really interesting, flexible, fully integrated and self-powered eSkin platform that can provide real-time data to a user interface through Bluetooth. And it's a soft Band-Aid-like eSkin that can detect a variety of different things, including glucose, pH, ammonia, urea, and is able to really monitor a variety of different physical parameters like temperature and strain and pressure, those sorts of things. So really interested to see how the applications of this technology evolve. And in the area of informatics, there's timely identification of patient deterioration is really crucial to patient safety. So what this group has done is really been able to mine nursing notes to be able to very much earlier and more accurately, fairly accurately detect when risk factors are beginning to be identified for patient deterioration, and are really sort of, there's a lot of different applications to this, and the findings demonstrate that using this minimal annotation unsupervised method using AI can really help to rapidly mine these sets of phrases from a large amount of notes, and really could be quite useful for predicting risk factor identification. And just finally, I wanted to mention the feedback campaign that we opened up earlier this year. So NINR concluded this 3-month feedback campaign on what does nursing research mean to you? And this is really an opportunity to highlight the variety of different perspectives and benefits of nursing research. And we thought it would be sort of a multi-faceted campaign, in that it could be kind of fun to learn what the community thinks about nursing research and what it means to them personally, but then also to get some insights into our strategic plan, and hopefully help to provide some guidance into some of the areas that might be useful to consider for that plan. And we received over 380 responses, which is great, and really thank everyone who was able to contribute. And on this slide, and I won't go through them in much detail here, but we the very early preliminary results of this campaign, as we're still going through to analyze the results, are, there's a lot focused on promoting quality of life, health, wellness, and well-being, as you might expect. Highlighting the practice-based scientific inquiry, really to help, build that evidence base for patient-centered care, and a variety of other different elements, including the importance of exploring social determinants of health. So with that, I just want to remind everyone to check out our website, because there's a lot of information that was provided in these slides, and you can find almost all of it online on the website. And then, before we move on, I will sort of do this proverbial passing of the baton, but I do want to take a brief moment here just to thank each and every one of you, both our council members, the extramural community, and our NINR team, really for the very warm welcome, and really importantly to me, a lot of tremendous support over the last year. It has really been valuable. This has been an incredibly rewarding experience for me, and something that I will obviously always cherish. As I said, this was my sort of homecoming in a way, because I started my NIH career at NINR, and it's been such an experience to be able to come back to NINR to help sort of keep things going, keep the ship going, with the help of an incredible team over the last year. And I have been so just impressed by people's commitment and dedication and willingness to help out and be flexible. And that to me just signifies that the Institute is in a really good place for Shannon to come in and make her mark. And I really am excited to see what the Institute and the field has in store for it over the next several years. And under Shannon's leadership, I'm sure she will help grow and advance the Institute. So you have another cheerleader from me, as I'd normally say, across the parking lot, although none of us are on campus currently. But yeah, I just want to just take that moment to say thank you to all of you for everything over the last year or so. So with that, I'm going to turn it over to Shannon, because I know that she has a lot of really interesting things to say about the future direction of the Institute.
Thanks, Tara. Let's
see if I can, I lost, I lost my Zoom thing to stop sharing slides. So maybe Nathan, can you just grab it real quick? Oh, there it is. Okay.
All right, so can you see my notes or do you see just the slides?
We see the slides.
Okay, excellent. Just want to minimize this. Okay, well, good morning, everyone. It's just what an honor for me to join NINR as the next director. And I'm delighted to be able to participate in my first council meeting so soon. I'm fortunate to know some of you already. Actually, I first met Dr. Paragallo and Dr. Joellen Wilbur during my nursing studies. And Joellen sponsored my NINR funded KO1 award. Several of you I've met more recently, and I look forward to creating opportunities to talk with each of you in the upcoming weeks. The council is one of NINR's critical connections to the extramural scientific community, so I very much look forward to our valuable time together. So before I go further, please join me in thanking Dr. Tara Schwetz for her outstanding leadership of NINR this past year and her commitment to nursing science. Thank you so much, Tara. I feel really fortunate to follow your tenure at NINR. So because it's our first council meeting together, over the next 20 minutes or so, let me tell you some about me, about my love of science, and some thoughts I have about today's health landscape and their meaning for NINR science. Then we can have hopefully some time to begin to dialogue and many conversations in the future. So my educational background is a strong integration of nursing and public health. My predoctoral training at the University of Michigan was in psychosocial factors and mental health and illness. And my postdoctoral training at the University of Illinois, Chicago focused on cancer control and population sciences. For the past 14 years, I've pursued research, teaching, and service as a faculty member at the UIC College of Nursing. My program of research focuses on social inequities in health, with the goal of identifying effective strategies at multiple levels to improve health and eliminate racial and socioeconomic health inequities. Much of my work is on community environments, particularly the food environment, and energy balance related behaviors and conditions. So there were several experiences that led to my interest in community environments. Early in my career as a home health nurse, I was struck by the tremendous differences in the home and community environments of the patients in my caseload. The stark contrast of patients' living conditions, both in terms of privilege and poverty, and the impact of those living conditions on their health became really evident to me. As a PhD student, I worked on several community-based participatory research projects in Detroit. And as part of that, I had the opportunity to listen to residents describe the lack of food, healthy foods in their communities, as well as the wide range of unhealthy options seemingly everywhere in their communities. And so listening to their stories really sparked my interest in food access specifically. So these were the type of experiences, starting as a home healthcare nurse, and then in my studies, PhD studies, that played a big role in shaping my research trajectory. I conduct all my research using a team science approach. My colleagues and I conducted some of the very early studies on food deserts in the United States. Across multiple studies in Detroit, Chicago, and nationwide, we documented that low-income Black communities had poorer access to high-quality healthy foods and food sources, and greater access to unhealthy food sources and options than higher-income white communities. We've since produced evidence on the implications of those social inequities for individual health behaviors and related health outcomes. For example, in a multi-ethnic sample in Detroit, we found that the availability of a nearby large grocery store, which tend to have a wide selection of healthy food options, that was associated with consuming more fruits and vegetables compared to those who did not have that resource nearby. And using longitudinal data, we also found that having nearby small grocery stores or corner stores, so these are small stores in urban environments that tend to have a lot of unhealthy options, that was associated with higher body mass index. Over the years, we've developed new approaches to improve the measurement of community environments and environmental exposures. For example, we recognize that studying the community environments where people live and not the other community environments where they spent time, that might misspecify environmental exposures and misdirect interventions. So to more accurately measure environmental exposures, we were early adopters of GPS tracking to study the broader activity-based community environments and energy balance related behaviors. Over time, my research has become increasingly multi-level. In one line of research, we've evaluated whether the effectiveness of behavioral interventions differs depending on individuals' community environments. We hypothesize that differences in individuals' environments may contribute to the tremendous individual variability observed in behavioral intervention effectiveness, including unsustained behavioral change outcomes. In a recent retrospective study, we tested this hypothesis in a nationwide weight management program offered by the Veterans Administration. Drawing on electronic health records of approximately 2 million men and 150,000 women and using a quasi-experimental design, we found that men living near the most convenience stores and the most fast food restaurants lost less weight at 6 months compared to those with the fewest of these outlets. Our recent work combines behavioral sensors with other real-time data collection approaches to identify how environmental and personal factors, trait and state, interact to affect energy balance behaviors. Among our questions in this line of research are, for whom does the environment matter, such as those with low executive function? And under what conditions does the environment affect behaviors? It may be that under conditions of stress that the environment is particularly influential. Now that I'm at NIH, I'm glad that I'll have the chance to continue my research through NIMHD's intramural program. I also see 3 key experiences that I think are bound to influence my role as NINR director that I thought I'd mention today. Through my many collaborations with top scientists across multiple disciplines, I've gained a breadth of experience in and appreciation for different types of scientific approaches. This includes community-based participatory research, qualitative research, secondary analysis, and research evaluating policy and other macro level interventions. Like many of you, mentoring future scientists has been a really valued part of my career. My research group has always been multidisciplinary, including, for example, students in nursing, public health, economics, psychology, and urban planning. And I've learned so much about promoting scientific excellence through my peer review service and leadership. For example, I recently served on and this past year chaired the Community Influences on Health Behaviors Scientific Review Group here at NIH. I've also served as associate editor for a variety of international and interdisciplinary journals. I've immensely enjoyed conducting research on issues and populations that I care about and with colleagues from whom I've learned so much. And I've enjoyed being a nursing faculty member. But when I began having conversations about the NINR director position and learning more and thinking about NINR's current science and scientific possibilities, my excitement really grew and I became really interested in contributing to science in a different way. So as we move forward, NINR certainly has a strong legacy of accomplishments to build on. There's much to be proud of. NINR extramural and intramural researchers have advanced science in a number of key areas, such as patient symptoms, self-management, wellness, and end-of-life and palliative care. as well as helping to train countless nurses, including myself, to conduct rigorous research, including in emerging scientific areas such as genetics and methodologies. Yet, as we scan the current health and healthcare landscape, it's clear that our work at NINR and in nursing science, that it's not done. There's more to do. More than ever, we see the need for more and better knowledge, technology, healthcare, and public health services to improve the nation's health. We face pressing challenges affecting the public's health and persistent large health inequities for which we have an incomplete understanding and insufficient solutions. In the current landscape, racial and social injustices have gained broader recognition, including their wide-ranging health effects. Public demand is high for deep and enduring change so that everyone has the opportunity to live a long, healthy life. At the same time, our nursing practice colleagues see the embodiment of these challenges every day. They recognize it as having root causes beyond the individual and are counting on nursing science to find real practice and policy solutions. The COVID-19 pandemic illustrates a number of our challenges. The COVID-19 pandemic has exposed weaknesses in the preparedness and practices of our public health and healthcare systems, while also showcasing the ingenuity and critical contributions of nurses across community and acute settings. Sobering systematic differences by race, ethnicity, and socioeconomic status have emerged in the risks of infection, serious illness, as well as death. The COVID-19 crisis has also illuminated the powerful contributions of the conditions in which people are born, live, work, play, and age, and the forces that shape those conditions or social determinants to disease risk and disparities. It's demonstrated, for example, how the risk of infection differs by occupation, as well as material resources such as public transportation, the amount of living space, and running water. During the pandemic, a variety of social determinants have also impacted people's ability to promote their health and manage other health conditions. For example, the pandemic has affected access to preventive services, to food and groceries, and to open space for physical activity and stress relief. The hallmark to me of nursing is our holistic perspective. Since at least the time of Florence Nightingale, nurses have understood that supporting people to promote and restore their health means addressing needs at multiple levels, physical health needs as well as emotional, social, and economic, and creating favorable conditions, environments, and systems. This holistic perspective that characterizes nursing uniquely and ideally positions nursing science to meet current health challenges and uncover groundbreaking practice and policy solutions. Our responsibility is to increase our impact in solving the most pressing health problems and the most stubborn health inequities by collaboratively taking nursing science to new levels. One direction that I think is critical is to draw on our holistic perspective and push the scientific boundaries of multi-level integration from the molecular to the macro. To me, science on multi-level integration involves studying how factors at multiple levels interact to affect health and the real-world effectiveness of promising interventions. These levels can extend from molecules at the biological level up to social determinants and macro-level factors. To maximize the impact of our scientific breakthroughs and multi-level integration, it's also important for us to prioritize translation in our science. Prioritizing translation might mean focusing on practice and policy relevant questions from the very start, advancing the science of translation, which identifies how to effectively move scientific breakthroughs into practice and macro level change, and infusing translational science into pre and postdoctoral training. There's much to consider and discuss regarding how nursing science and NINR can push scientific discoveries and multi-level integration and prioritize translation into practice and policy. Know, though, that I intend to listen to you and to a variety of stakeholders at NINR, at NIH, and more broadly, to look at data and to learn. Examples of questions for our joint consideration include, for example, what are the key scientific areas and opportunities in multi-level integration? Given health inequities are a top priority for NINR, how can we eliminate systematic health gaps? And are there particular inequities that we should focus on? What factors at multiple levels are most important to address and integrate through our research? And what kinds of training do we need to push scientific integration of upstream and downstream factors and their translation? So I really look forward to talking with you about the details in the weeks and the months ahead, and working with you to push scientific boundaries and multi-level integration and prioritize translation of these discoveries into practice and policy, and ultimately to continue to increase the impact of nursing research. So with the few minutes we have remaining, I'm happy to begin that dialogue. And one question that we could consider is, what do you think are the key scientific areas in multi-level integration and translation? So I'm happy to start there, or with any other questions or things that are on your mind. Thanks.
Thank you, Dr. Zank. It's exciting to hear your vision, and we've been anticipating your arrival for some time, so it's great to have the opportunity to get to know you better, both professionally and personally. We're looking forward to identifying and implementing your ideas and priorities. And so if there are any questions from our council members, this would be the time for us to take a couple.
Well, this is Kai Moore. I don't necessarily have a question, but I really enjoyed your presentation, Dr. Zink, and I'm also thrilled that you're here. I think you'll bring an excellent blend of behavioral intervention work, and hopefully we'll see ways that the biobehavioral work of the Institute can continue to go forward as well.
Hello, Shannon. I don't have a specific question either, I guess, at this point. I've known you well for a long time, and I'm really thrilled to see you here. And I'm thrilled about your bringing your background in big data sets and all of the social determinants of health, important work you've done over the last so many years. And welcome. Really pleased to have you.
Any other comments before we move on to our next speaker? Okay.
Well, if not, thank you, Kay. And again, I'm looking forward to many conversations in the weeks and months ahead, and really look forward to working with all of you. So thanks so much.
As are we. Thank you. Okay, our next guest is from the NIH's Center for Scientific Review, Dr. Delia Alufakunbi-Sam, who will describe the upcoming study section changes that are relevant to NINR's investigator community. Dr. Alufakunbi-Sam is the chief of the Healthcare Delivery and Methodologies Integrated Review Group at CSR. She's also served as the CSR Scientific Review Officer Training Workshop Coordinator. And prior to joining CSR, she was the Deputy Director of the Center of Integrated Behavioral Health Policy at George Washington University. Her research is focused on behavioral health policy, substance abuse prevention and treatment, minority health, and child welfare. So welcome and thank you. You can go ahead and share your screen to advance your slides.
All right, thank you, Kay. So let me see if I can figure this out. All right, do you guys see my screen?
Yes, we do.
All right. So let me just move this here a bit. All right, so thank you for having me. I see some familiar faces of folks who have reviewed for HDM in the past. I want to thank you for your service, and it's really good to see you in this context. I'm going to be talking about some recent changes that we have made to the healthcare delivery and patient outcomes cluster, of which most of the study sections within the healthcare delivery and methodologies IRG are a part of. And so I'm going to talk about these changes, talk a bit about the new study sections, and then answer any questions that you may have around the changes. So let me see. All right. So at CSR, we have a framework that we use to assess the quality of our peer review process. And that framework involves sort of 3 prongs. One is our reviewers, our reviewer pool, then the process of peer review, and then our study sections. In terms of the reviewers, we consistently look at how we are training our reviewers to make sure that we have a consistent approach to training across all the study sections, to make sure that our process is transparent, and to make sure that we give our reviewers the tools they need to be able to conduct the reviews in a fair, unbiased, and sort of expert manner. We also really focus on trying to broaden the pool of reviewers that we have. One, so that we don't overuse reviewers and exhaust them, but 2, to make sure that we are sort of having fresh eyes and really sort of diverse views engaged in our peer review process. We also evaluate our reviewer performance in terms of making sure that they are qualified, that they sort of meet our expectations in terms of expertise and qualifications, to make sure that their critiques are providing really qualitative, substantive feedback to the institutes, and that there aren't any irregularities in their scoring behavior. So that one prong is the reviewers. We also have the process. And here we really pay attention to the integrity of our peer review process. We look at potential bias in review. We look at how we are assigning and referring applications to make sure that they are in the right place, in the right home. We also look periodically at our review criteria and our scoring system to make sure that we are really identifying the key variables that will lead to quality and the identification of high impact applications. And then the third prong is the actual study sections. And for this, we do a periodic evaluation of the scientific boundaries of all the study sections that we have. And that includes an assessment of sort of the output data, as well as the size and scope of the study section. And so what I'm going to talk about today is this third element, the study section evaluation. So we have a process called NINR, and it stands for Evaluating Panel Quality in Review. And with this process, it involves a critical assessment of the output of the study sections by a specific scientific cluster. And based on that assessment, recommendations to changes to the study sections that really ensure that the scientific scope and the function of the study sections are really designed to identify high impact science. And
Dr. Olufokunbi-Sam, I'm going to jump in, and I think your slides aren't advancing.
Oh no. Okay. Do you see NINR at all?
We still see your title slide.
Huh. Okay. Let me stop and try again. Sorry about that.
No worries.
Let me know if it doesn't, because it could be maybe because I'm in PowerPoint. Maybe. Can you see NINR now?
We do. Yes.
Okay. So let me just, if you could tell me, I'm going to switch the screen. Can you see that? Did it switch?
Yes, it says inquire, process, and timeline. Yes.
Okay, good. Let me know if it doesn't switch. I'm not quite sure.
Okay, great.
All right.
Thank you.
So The process. We have a multiple stage process in this inquire. One is the identification of an external working group. This is a group that includes some pretty broad senior level scientists in the community, and they are charged with assessing whether the scientific scope of the individual study sections that we have really support the identification of high quality research. And we give them a number of tools and resources to do this evaluation, including the scientific guidelines of the current study sections, any workload trends in terms of are the study section, are the applications that are coming into the study section really beginning to grow because of new emerging areas, or is it sort of dwindling down? We give them a sample of abstracts and scientific aims of for the study section, as well as some bibliometric output variables for them to evaluate. They then come up with some recommendations, which then goes to our internal process working group. That group includes some senior level IC folks, representatives from the Office of the Director, and CSR leadership. And they really look at the review process. So the first stage is looking at the scientific scope. The second stage is an internal review looking at the process. And they take into consideration the work group, the external work group's recommendations. And then they look at sort of how do we sort of conceptualize this internally in terms of how the study sections are structured and what changes may need to be made to the study sections in order to meet the recommendations for the external panel. And for this, they look at scoring patterns. We do surveys of sample of reviewers. We do surveys of program officials. We also do some site visits of the study sections to get a sense of the discussion dynamics and the culture of the study section. And we also look at early stage reviewer application and award rates. And from there, we take the two recommendations and combine them to develop a work plan that we present to the NIH Extramural Activities Working Group, which composes of a number of senior level multi-IC policy advisory groups to the NIH Director, as well as a CSR Advisory Council. For approval of whatever recommended restructuring that we think meets the goals of the two internal and external working groups. Once the recommendations have been approved, we then come back to the internal staff, figure out how we logistically make changes to accommodate those recommendations, and then we implement. And we are now in the stage of implementation. Can you see the next slide? Okay, great.
Yes.
So, last year we had four clusters that were reviewed through this inquire process, of which the healthcare delivery and patient outcomes was one of the clusters, and that's the one I'm talking with you about today. But the four clusters pretty much covered about 42 study sections within CSR, about 24% of all of our study sections. So as I mentioned, we are now in the implementation phase of the process. We will be implementing the new study sections for the 2021-05 council. So that's for applications that are submitted in October for review in February. So it's coming up for the next council round of review. And the study sections that are going to be ending include 2 study sections from the risk prevention and health behavior IRG, as well as 7 study sections from the healthcare delivery and methodologies IRG. And these are the study sections that are going to be ending. And then the new study sections, we will be adding 11 new study sections, 2 that will go to RPHB, and then 9 that will be within HDM. And so these are the new study sections that are going to be coming up. I'm going to talk about them slightly individually. We have two study sections that are focused kind of at the individual level of health, the biobehavioral medicine and health outcomes, and the lifestyle change and behavioral health study sections. These are two study sections that are in the risk prevention and health behavior IRG. These are really focused at the individual level. And then at the community service level, we have three new study sections. One, the science of implementation in health and healthcare focuses primarily on implementation science. Our previous implementation science study section was called DIRH. The new study section has really been fine-tuned to really focus on the science of implementation. So really kind of phase 2, phase 3 implementation science, or type 2, type 3 implementation science. Really looking at sort of the use of implementation science to implement evidence-based interventions within communities. Then we have the healthcare and health disparities study section. This study section will focus primarily on the systemic underpinnings of healthcare disparities, with a focus at the health service, healthcare system, healthcare services level. So this isn't really about it's not about disparities at the individual level or at the population level. It's really looking at the healthcare system and health service level. We have the health promotion in communities study section, and this is looking at the community level, so interventions at the community level or other non-clinical settings. All right, and then we have two study sections focused on clinical management, and these two study sections might be of most interest to NINR. Our clinical management in general care settings, CMGC, and our interdisciplinary clinical care and specialty care settings, ICSC. I'm still trying to get used to all our new acronyms. But the CMGC really focuses on clinical management of patients from the provider perspective in general healthcare settings, while the interdisciplinary clinical care and specialty care settings focuses on the clinical management of patients, but in the institutional and inpatient settings. And that's really the distinction between the two study sections. One is sort of general practice or general care settings. The other is in institutional inpatient settings like hospitals, hospice, inpatient facilities. But the key is that these two study sections really focus on direct patient care and really should have some clinical implications in terms of practice. Then we have two study sections that are focused on health services research. We have the health services quality and effectiveness and the organization and delivery of health services study section. The HSQE focuses really on health services, is that me? Health services and looking at the connection of health services with individual patient level health outcomes, focus really on the access, receipt, utilization of services, cost effectiveness, comparative effectiveness. The organization and delivery of health services study section focuses more at a higher level at the organization of health services, really looking at kind of healthcare financing, insurance, access, utilization, but really at the population level. All right, and then finally, our two clinical informatics study sections include the clinical data management and analysis and the clinical informatics and digital health. The CDMA focuses more on sort of the development of computing technology, simulation data models, and the clinical informatics and digital health really focuses on the sort of technology-based approaches, tools to healthcare delivery. So it's kind of clinical decision-making, support, IT, health IT interventions, mobile health, kind of really on the sort of practical implementations level. All right, and so those are our new study sections that are going to be coming up for the 2021-05 Council. One of the key things that the key sort of feedback and what we've been quite mindful of as we redesign our study sections in this particular cluster is the need to really be in tune with the growth and changes in research and in healthcare research, and the need to really integrate key methods and approaches across all of our study sections, as opposed to having them siloed in a particular study section. And this is particularly relevant for our bioinformatics, big data, and health research, our nursing and clinical sciences applications, our health disparities and social determinants of health, and implementation science. And our approach is really to make sure that we are integrating these areas of science across all of our study sections, so that we can really assign applications based on what they are doing and what the specific expertise need is, as opposed to sort of the domain and really sort of in the past where they've kind of been siloed into a particular study section, really sort of transferring that knowledge base across all of our study sections, particularly as we enter sort of this multidisciplinary approach to doing research. And then this couple last slides are just kind of for information for you. If you go to our website, you'll see the study sections that are ending, and then the new study sections, and you'll be able to click on the links and get a broad description of what each of the study sections cover, what their guidelines are. And then finally, these are just some links to more information. If you want more information about the Inquire process and what the specific recommendations are, you can go to our website. We also have some information about the ongoing evaluations that we have been doing related to bias and just a range of research activities that we've been doing internally within CSR. And then, as I mentioned, you can go to our website and click on the individual study section links to get a sense of what the specific guidelines are for each of the study sections. And that's pretty much all I had for you. So I'm going to stop sharing and then answer any questions that you may have.
Thank you so much. That was very useful information. I really appreciated how you did such a good job of describing what the different study sections focus will be. And now's an opportunity for our council members to ask questions and to get a better sense of what the investigator community might be thinking as well. And I want to kick off that discussion by asking you, even with the description that you've given, if an investigator is still not sure which review group is going to be appropriate for an upcoming application, what would you recommend? For instance, if two groups sound like they could be appropriate, how would they best decide which might be the best match?
So there are a couple of things that PIs can do. One, we have a study section request form. And so they can always put both study sections or however many study sections they think would be an appropriate fit for their application on that study section request form. We always consider PI requests in placing applications. We don't always honor PI requests because, we have a pretty thorough understanding of the study section makeup. And so we have a better understanding of kind of what the reviewer expertise is on each of the panels. And so sometimes a PI's request may not necessarily be the best fit. And so we will put the application in the study section that we perceive to be the best fit. And we'll let the PI know sort of why the application was put in a particular study section. But they can always request 1, 2, 3 different study sections that they think might be a good fit. And then they can also contact the SRO for a particular study section that they think would be a good fit, to have a conversation to say, here, take a look at my abstract or my specific aims. Do you think this might fit well with this study section, or do you have recommendations for a different study section? again, we don't really know until we get the actual application. So the SRO is making a judgment based on the specific age, and that may not necessarily align well when we actually get the application. But that's another opportunity to have a discussion about what the potential fit is. And then ultimately, we try to let PIs know that they don't have to request a study section. We do a thorough look at the application to determine where we think the best fit would be. So they don't necessarily have to request a particular study section. We do look at the science that's proposed, we look at the study sections that we have, and we do determine the best fit on our end.
Thank you. That's a nice comprehensive answer. Thank you. So do we have any other questions?
Very nice to see you here. And
you too.
Yeah, looks like almost all the study sections are being reorganized. So my question is, what were the urgent needs behind this big change? And what would be the implications for nurse researchers, especially those who are aiming at the NINR for funding? Mm-hmm. Any advice?
So in terms of your first question, there wasn't any particular specific impetus outside of we make a point every year to review the science in a particular cluster. And so this was our time to really take a look at the science and whether the study sections were appropriately meeting the needs of the science. Many of our study sections were becoming a bit oversubscribed. And we did, as we take a pulse on the science, there are some emergent areas that the study sections kind of need to adjust to. And so this is part of our process of really saying, where's the science right now? And are these study sections best meeting the needs of the scientific area? And so that's sort of the cause of the inquiry process for us, in this round. And in terms of your second question, we still have the two key clinical management study sections that really sort of deal with clinical services and clinical practice. And I imagine many applications that come to NINR may end up in those two study sections. But I do want to highlight the fact that we are really trying to make sure that all of our study sections, at least within this IRG, and I think divisionally as well, all of our study sections really have some level of clinical management expertise, so that applications don't, NINR applications don't get siloed into those two study sections. We're really trying to say, let's put the applications where the best scientific fit is and make sure that all of our study sections have the appropriate expertise and have sort of clinical management expertise on them, so that there isn't, I think in the past there's been a concern that, well, if it gets put in this study section, they might not have the clinical expertise that, is really important for my particular application. So even though it doesn't quite fit the nursing study section, I want it in the nursing study section because of the clinical management expertise. And what we're trying to do is really say, okay, all of our study sections need to have clinical management, clinical care expertise to really reflect the science and, recognizing that there is a lot of interdisciplinary research that's going on, and we need to make sure that all of our study sections can appropriately review that.
Oh, gotcha. Thank you.
I would also, looking at all the new study sections, I would hope that you would have, nursing representation in those new study sections. I mean, are there any, efforts to do that? Because I think nursing is not limited to those two study sections. Nursing research is not limited to those that you mentioned.
Yes.
It falls into many other areas.
Yes, and that's really sort of one of the main focuses that we have with this reorganization, is to recognize that nursing expertise should not be limited to those two study sections, that we really need to make sure that we include clinical management expertise, of which nursing is one of them, right? Across all of our study sections, just as we are trying to make sure that we have social determinants of health expertise across all of our study section, and implementation science expertise across all of our study sections, so that none of these get siloed, and no particular research area or clinical focus gets siloed into a particular study section. So yes, that is our goal. Now, we are going to be gradually building the study sections, and so you will see an increase in the representation of all these science areas over the next couple of years as we begin to really populate each of the study sections.
Could you please tell us again when the effective date is?
So the effective date is for the 2021-05 Council, which means it's for applications that will be reviewed in our February meeting, for applications that are due starting in October. So the October 5th R01 deadline will be sort of the first group of applications that will be assigned to these new study sections.
Hello, Delia.
Hey, John.
So the new study sections will be aligned with all of the new initiatives around COVID and ready to respond to those applications. Or how does it align with?
So we have some specific COVID-related PARs, program announcements, that will be reviewed depending on what sort of the agreement was with the institutes, that will most likely be reviewed in special emphasis panels focused on that particular COVID-related substantive area. Then there are going to be COVID-related applications that are investigator-initiated applications just based on what's going on, and those will be assigned to the relevant study sections based on what they're proposing to do.
Hi, this is Joanne Wolf. I think one of the worries that in general individuals have is a sort of understanding of expertise amongst the reviewers in various different topics. So for example, I represent the hospice and palliative care research community in some ways on this council, or to a certain extent. And it sort of feels like the expertise in that area will be diluted, for example, now across study sections, which wasn't the case previously. So I'm curious how that gets addressed with this sort of reconfiguration.
So the expertise, particularly in our two clinical management study sections, are not going to be diluted. So we're not taking reviewers from our clinical management study sections to put them elsewhere. Those are still going to be, and those haven't changed that much from sort of what they used to be. So the expertise that are there are still going to remain there. And what we are doing is increasing expertise in clinical management across the other study sections in addition to. So we're not moving people out of our clinical management study sections. We're saying, we still have these core areas of clinical management that need to remain there, but we also need to add additional expertise to the other study sections. So depending on what the application is proposing to do, it may belong in the new clinical management institutional care study section, but we're just trying to make sure that we have representation across all the other study sections. Does that answer your question? Or?
To a certain extent, thank you. Okay. Yeah.
Hi, I do want to say that I really appreciate the descriptions and the additional details that you've given us, because I think that helps fill some gaps in knowledge that I think a lot of us were dealing with as far as how all of these study sections were going to potentially be implemented, and where some of us might see ourselves within those study sections. And One of the issues that I think a lot of folks have had recently is finding a good home for your applications where there's an appreciation for your methodologic approaches coupled with your phenotypes or patient population of interest. And I think that that has been a concern for a lot of folks, that you could have one or you could have the other, but it was rare to find something where there was a nice home that you know, really appreciated, for example, the focus on patient outcomes, while you were bringing in some approaches that sometimes would get your application kicked out to another study section. And so I'm glad to see that there's a little bit more of an effort to distribute across the study sections. One of the things, though, that wasn't mentioned, you talked a lot about you know, how to distribute, you know, certain types of approaches and expertise, but I didn't see anywhere where there was an attempt to make sure that there was adequate representation across these study sections that nursing science might be represented. You know, of course they can go anywhere, but better represented in some of these study sections that you presented, where the physiologic and the biologic would have a good home amongst some of those study sections. So I just wanted to sort of give a shout out for that, because I don't think that that was given attention in the descriptions. And I've read some of the descriptions before, and there's not a whole lot of the new study sections that actually look like they're going to embrace the physiologic and the biologic approaches. So I just wanted to put that out there to make sure that we're meshing the nursing lens with the biologic as well. And so I just wanted to get your thoughts on that.
Yeah, so, you know, our particular IRG is really focused on kind of healthcare service, healthcare, clinical management, and kind of community-based intervention. And we have other IRGs and other divisions that are kind of focused on more of the biological, genomic aspects of the science. And so, you know, there is a recognition that we are, again, sort of this interdisciplinary approach where you could have an application that has kind of multiple layers of analysis, right? So you can have a biological genomic element to the application that leads to translation, or that leads to some sort of specific health outcome research. And so we recognize that, and I think that's still a work in progress. But we do have some IRGs or some study sections that have a better design, particularly our sort of epidemiology study sections that kind of look at the genomic and the epigenomic all the way out to actual patient outcomes. So we do have some of those study sections reflected. So this is just a snapshot of one aspect of the broader study section variability, you know, very broad range of study sections within CSR. And so this is just, you know, one area focused on healthcare delivery and services. And there are other study sections that deal with more of the biological or translational science.
Right, right. And I would say that some of those study sections would benefit immensely from the nursing lens.
Mm-hmm. Yeah, I will make a note for that. That's a great point.
Well, I received a question that might be a nice follow-up to that discussion, and that is, what recourse do investigators have if they believe the new review group to which their application is assigned doesn't have the appropriate expertise? For instance, if they lack nursing science expertise or nurse scientist reviewers.
So there are a number, there's a process that we go through internally. So if you are assigned to a particular study section, usually the roster for that study section is released 30 days before the meeting. I always tell PIs that you can't necessarily judge the expertise of a particular panel for a particular round solely on the standing study section roster, because that, you know, we tend to add about 30% more reviewers as ad hoc reviewers to meet the specific scientific needs of the application pool for that particular round. And you can't necessarily use last rounds roster because, again, the applications that come in change or are different, and we really do sort of recruit additional reviewers based on the unique needs of that study section for that particular round. But usually the roster is available 30 days before the meeting. You can always have a conversation with the SRO if you have concerns about the placement of your application. And usually if you have a concern, you would talk to the SRO, you could talk to the chief of the particular IRG. We will then do another assessment of the application. We'll take another look at the application to see if there are alternative study sections that we can place the application in. If you don't particularly want a particular study section, if you don't think that there's sufficient expertise in that study section. There are times when the chiefs of the different study sections all agree that the application really belongs in this study section, and that they feel confident that there's expertise on that study section to review the application, and the PI is pretty certain that there isn't expertise. And in that case, when we reach that kind of stage, there is an appeal process where we sort of bring this up to DRR, and there's an appeals panel that looks at the application. And with the goal, I mean, ultimately our goal is to get the best review. And so we may disagree on sort of where that best review would occur, but that's ultimately our goal. And so the appeal group will consider the PI's request and determine, okay, you know, where do they think the best fit is? And that's usually sort of where the ultimate decision lies. So, you know, to answer your question, usually a conversation with the SRO or the chief to talk about what the specific concerns are with that particular placement. And sometimes a conversation is all that's needed, because either the chief can say, look, this is the expertise, and while on the surface it doesn't look like this person has the expertise, you think we do have expertise represented. Or it could be that the chief says, okay, I understand your concern, let's see if we can find a different study section that would better fit the needs that the application has, and sort of alleviate some of the concerns that you have.
That's really helpful. And so how about an application that was reviewed in a group that's now dissolved? What is the process for handling the resubmitted application?
So again, we look at what the application is proposing to do and determine what the best fit is based on what the application is proposing to do. You know, even in our current system, we don't necessarily promise continuity of review in that the same study section or the same reviewers are going to review the application. It really is, what is the application proposing to do and where's the best fit? And so in this realignment, we're going to be taking that same approach of what are the aims, what are they proposing to do, what kind of expertise is needed, and where is the best fit.
Does it still come in as a resubmission, or is it now deemed new?
No, it still comes in as a resubmission. Yeah, because the resubmission is associated with the application, not the study section. So it still comes in as a resubmission. The new panel, wherever it gets reviewed, will still read the, you know, the introduction, will evaluate how responsive they were to the prior review.
Any other questions? Well, I'll ask one last final quick one. When will the assisted referral tool, the online ART, be updated to reflect the changes in the study sections?
That's a great question. So we are still working on updating the ART tool. It will be useful this round, but this round it's going to direct you to the IRG of reference, not a specific study section. The ART2 is based on sort of prior applications that have come into the study section. The way it analyzes the data, it's based on prior. And since we don't have a history of the new study sections, it's going to give you a general recommendation of a particular IRG as opposed to a specific study section. As we get more fine-tuned, as the tool is able to get more data, right, to inform its referral process, we'll be able to make more targeted recommendations. But initially, it's going to refer to the IRG and not a specific study section.
This has been very helpful. Not only your talk, but also this Q&A section, I think has been very helpful, would be a great resource. So I want to remind everyone that should you have investigators asking you some of these questions, this talk will be archived and so can be referred to. And we'll also be distributing the slides to the council members as well. So again, thank you so much. We really appreciate it.
It was a pleasure talking with you.
Thank you. So our next speaker is Dr. Jessica Gill, who will provide us an update from the Training Pathways Working Group. Dr. Gill is a tenured investigator at NINR, a Lasker Clinical Research Scholar, and is the acting scientific director for NINR's intramural program. Today, she is presenting as the co-chair of the working group to examine the nurse research pathways and to provide recommendations for NINR to further develop pathways to support nurse researchers. So thank you, Dr. Gill. I'll turn it over to you.
Great. Okay. Thank you so much. And I'm working on getting my screen going. It looks like I've got too many things open.
Good luck.
It looks like it's there. I'm just gonna get this challenged by this before I apologize. Great. Thank you so much for the introduction. And I just want to extend another welcome to Dr. Zeng. We're really excited to see where your leadership takes us, especially in intramural. We've been waiting for some time, and so we're excited to see our new direction and see where nursing science will go. Today, I'm going to present on the NINR Pathway Nursing Research Group. I'm co-director of this group with Shirley Moore. Unfortunately, Shirley could not be here with us today, so I'm going to go ahead and present and take questions also. So the charge that we have for this working group came in early 2020 after a meeting at the NINR Council, where there were some questions posed about the pathway for the training of nursing research, and especially as we look into the training of the next generation of nursing researchers. And so really what we're charged with within this group is to provide NINR leadership with information about this pathway, specifically to identify strengths, limitations, as well as current challenges and future challenges. One of the other things that's kind of been a common theme throughout this is to look at issues related to diversity and inclusion, to really understand how we can diversify the workforce and really represent the overall population of the United States. Ultimately, our goal is to develop recommendations to enhance nursing research through education and training at all phases of education and training. And so it's really looking at those 4 million nurses out there and how can we engage more and get PhD nurses trained to advance nursing science. And so this is, of course, a project that I've been very excited to be included in. And I thank you to Dr. Schwetz for letting me lead in this effort, as well as Yvonne Bryant. We have 18 members in our group, including individuals here at NINR, as well as those across the country in institutions and different associations. This is some of the group, and then continued. This is also part of the group. And before I go on, I just want to, say thank you so much for this group. Their creativity, their positivity, their workforce, and their commitment to this challenge has really let us go to where we need to go for this and really put in the depth of knowledge and look at this in a creative manner. And so I'm so thankful to all the members of this working group for letting us do what we do. We could not do it without this group. It's really been an amazing opportunity to get to know so many new people and be engaged in such an important challenge. What we did with this working group is we divided into 4 subgroups. And the first one is really to look at current limitations in recruitment, looking specifically at factors that induce individuals to go into a PhD program, as well as those factors that might detract from it. specifically to look and understand if there's misrepresentation of the population and engagement in these groups and PhD progress, to look at minority and underrepresented populations. The second one is to look at training-related shortfalls and to understand their possible influence on the nurse researcher's ability to develop a successful program of research and also to be engaged in that and to progress. The third is to look at factors that hinder the nurse researcher's progression in their career, possibly leading them to exit being a nurse researcher and engage in different career trajectories. The last is to examine or to improve collaborations that we can have with NINR to engage with different organizations and institutions to really develop a diverse cohort of nurse researchers. And how can we collaborate? We know that there's a lot of other groups and individuals out there. How can we engage with them to do the best work we can to develop a cohort of nurse researchers for the next generation? And so what we've done, we started it in March 2020. We started holding our first meetings. We have the subgroups. Those meet about twice a month. And then we have an overall group meeting also twice a month. So the subgroups are generating a lot of things that then we discuss in our larger meetings. What we're looking for are common themes or ways that we can build these things together to provide comprehensive recommendations moving forward to really meet the need and the charge that we were provided. By December of this year, we'll have a final report, which will go to Dr. Zank and NINR leadership to then review. Following that, it will go to the council, in which will provide recommendations as well as findings from this overall working group, again, to see what NINR can do to make a real impact on the training of nursing researchers. In the written report, we'll provide background based on objective data that we've been able to obtain from NINR as well as from other organizations to really understand what the issues are and the critical challenges that we face. We're also generating findings, and those findings then inform recommendations, again, that are comprehensive recommendations that go across those 4 subgroups that will be provided to Dr. Zank, NINR leadership, and the council. So where are we now? What I talked with Tara about too is, it's great to hear the process, but where are we going? What are we doing? And so these are really early findings or themes that we're seeing across these cohorts. And so I'm going to share just a little bit with you. So one of the first themes is to foster cross-institutional mentoring and training. Probably like all of you, I think our working group has really been impressed that we thought we had to have virtual meetings, but we thought in-person would be better. And of course, sometimes that is, but finding the opportunities that come with this virtual environment to collaborate and connect with people across the globe in a remote nature has really made us think about how we can actually link people who are geographically challenged, and especially in schools of nursing that might not have as much opportunity to get intensive research training, both in methods as well as the content in which the individual is interested in pursuing. And so one of our things is to really look and encourage distance opportunities for training. Also to link research intensive institutions with those that are not necessarily research intensive institutions currently. And specifically to link those research intensive schools to schools that have greater diversity, both in income, race, ethnicity, and other factors. And so this may be a way to increase the number of PhD nurses that can pursue both methods as well as content expertise and not necessarily have to relocate to attain those different skills. The last one within this theme is to look at cross-discipline training opportunities to really encourage nurses to obtain methods and content expertise outside of nursing science, to get that expertise and then bring it back to build cohesive and integrative teams that can really build and transcend nursing science to meet our critical needs. The last overall theme I'll kind of go over is the idea that we need to engage nurses as early as possible in thinking about nursing research. So even going into high schools as well as undergraduate institutions and showing what these opportunities look like and how to get there. So one of those is to develop additional summer training opportunities at research universities that would be inclusive of all individuals, even if they're not attending a research-intensive university. This would allow for diversity as well as universal opportunities. Also considering an idea of having NINR support a cohort of individuals who come to NIH to do clinical and research training at a very early stage. Other ideas that have come up in this group are to support the integration of undergrads in future funding opportunities, and to do this at every level, including center grants, institutional training awards, as well as R01s and other R-related opportunities. The idea behind this is to show undergraduates what research looks like so that we can really pique their interest and show them how a foundation in research science can then lead them down a different career path. Also, to develop resources to describe research pathways. One of the things that we've heard echoed over and over again is that something like a doctor of nursing practice, the pathway is known, but for research, it's less described. So finding stories and exemplars of nursing research and how to make connections and opportunities created, including diverse samples of individuals, would be really where we could start to build up individuals at the beginning stages when they're most creative, most engaged, and most likely to really commit to this more long-term development of a program of research. And so that's kind of where we are with some of these. There's also some other ideas percolating. And so what I'll do with this is I wanted to save a good amount of time for questions and comments to really see where people think we're going, if this is a good direction and what you think. And then again, thank you for everyone attending, and especially in this amazing time when we've got a new director. So I'll take any questions or comments that anyone has. Thank you so much.
Thank you. That was really helpful to get a sense of what you're doing and what you're thinking about as you are moving forward. I'll start us off with the first question to ask: if anybody has ideas that they want to share with you as you continue the process, what would be the best way to share those ideas?
Sure. So interacting with me or Yvonne Bryan would be the best way. Also Shirley would be fine. So just getting us your feedback, your thoughts. So part of the process has been engagement with individuals who are stakeholders and who have been identified as leaders in nursing research. So there's been interviews that have been undertaken to address these critical issues. But if there's other people who were missing, what we really want to get is a representative sample to understand the issues. So we want all the information, any thoughts, any creative options, we're completely open to. So I would say the best step is to email me or Yvonne.
This is Joellen Wilbur. I think this is wonderful what you're doing here, and you've gathered some really good information. I think you're right on. I'm just wondering if you are collaborating with the regional groups like MNRS, who are so involved in this. And I think that's key, where many students go, and there's a lot of collaboration between the more intensive and the less intensive research schools. Those sorts of ideas have been percolating for some time, and they've been working on that.
No, absolutely. So what we did when we formed these group two was connect with those regional groups to make sure that we were getting representatives. We also have two students who are PhD students, one from the East Coast, one from the West Coast. And so that's really what we want to do. The idea is that we'll get these findings delivered to NINR leadership and then disseminate. This will probably not be a final document. I believe that it'll be evolving. And that's really what we want to do, is to engage with people, to listen, to understand, and to move it forward. And, you know, I'm from Oregon. So when I went to go get my PhD, you know, I didn't have a lot of options. I was, you know, there's one university. And so that was part of the idea of just how can we connect nurse researchers to provide this nexus of support for PhD students across the country. And so I agree. I think doing that regional connection is huge. And that's been one of the things about NINR, is we consistently attend those meetings. And I've been attending a lot of them, as well as I know Dr. Schwetz has and other leadership at NINR. And so we want to not just generate this, but get feedback and then make, you know, have critical considerations and make changes based on that moving forward.
So just a quick question.
Sure.
So are you getting the feedback from the currently funded T32 programs as well?
We are integrating some of that. So Dr. Banks, David, is on our consortium as well as we consider everybody at NINR to be part of the team. I think, with the centers, there's a lot of opportunity to engage as we move forward. So that would be, I think, a great opportunity. And then really just reconsidering how can we make training a focus in every single grant that goes to NINR would be important. It's already being done. And I think NINR overall, when we look at the data at NIH, is more training focused than almost any other institute. So we're doing the work, but I think we're a growing profession, especially in research. And so we need to focus as much as we can to get this next cohort trained, and then also support the individuals that are out there to make sure that there's progression of those individuals who are successful in the programs of research.
Okay, thank you.
Any other thoughts? And if I know this is not maybe the best forum, but I'd be happy to have a more focused group if individuals have, considerations or emails. We're really looking for creative ideas and new perspectives. So just please reach out to me if this is not the best forum.
Thank you so much. Really appreciate it. And I'm going to turn the meeting back over to Dr. Zenk to close.
Thank you so much. And I hope you all appreciated the update from Dr. Schwetz about the activities of NINR and NIH over the last several months. Thank you to Sam for providing more information on the CSR study section changes. I certainly appreciated the rich discussion and the feedback that we'll take back with us. And again, I appreciated this conversation on the update of the Training Pathways Working Group activities. I think we're all very excited to see your report and your recommendations, and to learn how we can be more effective at NINR in terms of training the next diverse generation of nursing scientists. So I'll look forward to that. So with that, I will bring this open session of the council meeting to close, and we will reconvene at 2 p.m. Eastern. So with that, thank you all so very much for attending, to the council as well as to the broader public for joining. Thank you.
Thank you.